Hello everyone and welcome to a special Childhood Cancer Awareness Month episode of CCLG's Research Talks for Parents and Public. I'm Ellie Ellicott and my job is sharing research with our supporters. So starting with some housekeeping, we'll be holding a Q&A session at the end of the talk, so please do submit your questions whenever you think of them using the Q&A button that is at the bottom of your screen. If you'd like to use the chat function, please make sure that you set the to drop down to everyone or people may not see your message. So this webinar is being recorded and will be available publicly on our YouTube channel, so we'll send out the link when it's ready to watch. This month's talk is called Are You Child Cancer Smart? And is being led by Dr Shaarna Shanmugavadivel. Shaarna is a children's emergency doctor working on a PhD in childhood cancer diagnosis. She worked on the national award-winning HeadSmart campaign, an awareness campaign that aims to speed up brain tumour diagnosis for children in the UK, and is now CCLG's Child Cancer Smart Research Fellow. So, without further ado, I'm going to hand over to Shaarna.
Thank you so much, Ellie. I shall now share my screen. And hopefully this will work. So thanks, Ellie, and thank you everyone who has joined. It's really lovely to be here and to be able to talk to you about Child Cancer Smart. So as Ellie said, I am not an oncologist. I work in the emergency department, and so this is something that has been really important for me professionally as well, making sure that I am spotting children and young people who may have signs and symptoms of cancer. And that's how I came into this world about 15 years ago now. So what is Child Cancer Smart? So Child Cancer Smart is an evidence-based public and professional awareness campaign. And it is aiming to improve early diagnosis of cancer in children and young people. It can be really hard to spot cancer in children, and many of the symptoms are really quite similar to other childhood illnesses. So it's something that we've been working towards for about 10 years now, and we're really excited that we have finally launched. Right, to go forward. So how did this all begin? And this is a picture of Bethany Polanco, and she sadly died from a Wilms tumour, and her mum came to me at a research event and asked me about HeadSmart. She was really excited about how successful HeadSmart was, but the question she asked me was, why doesn't this exist for all the other cancer types? And it was a question that I hadn't actually thought of before. And since then, we've been working together for the last 10 years, doing a lot of the background work that needs to be done when thinking about setting up a campaign like this. So the HeadSmart campaign was really successful because it was based on evidence. And that meant that we knew that the support tools and the advice that we were giving families and healthcare professionals would pick up the children that needed to be picked up for scanning and for diagnosis. So talking about evidence, the campaign is really based upon a landmark study that we did called the Childhood Cancer Diagnosis Study. It was set up in the UK just as COVID was about to start, so we had to delay the start of the study. But what we really wanted to know was what symptoms children and young people experience when they are diagnosed with cancer, who they go to with these symptoms initially, and how long it takes before the diagnosis is reached. The aim of the study really was to understand the referral routes, like I said, and the time to diagnosis, and really to identify if there were any factors that would have been associated with a lengthier interval to diagnosis. So we recruited 1,957 children and young people, and all incident cases, and what we mean by that is all children who were diagnosed with cancer at the time were eligible to take part. So they were invited to be part of this study. And this was across all the large principal treatment centres in the UK. And the study was open between September 2020 and March 2023. And obviously we did take consent from parents and families to take part. Now, data that was collected were demographic factors. We collected postcodes to calculate index of multiple deprivation. We tried to find out which referral pathways they came through and also the clinical symptoms. And we also collected a number of dates. So these dates enabled us to calculate what we call the patient interval. So that's the time from when the child or young person experienced their first symptom to when they first went to see a doctor. We had dates that then enabled us to calculate the diagnostic interval. So that was the time point from when they first saw their doctor to being diagnosed. And then the total diagnostic interval was those two added up together. So, of the 1,957 children and young people, 54% were male, 78% were white, and the majority of cases were diagnosed were leukemia. And this all fits with nationally published cancer statistics from the Cancer Registry. We also looked at the number of visits and contacts before prior to diagnosis. So of these children, 74% had 1 to 3 visits to a healthcare professional prior to diagnosis. When you look at this graph here, the sort of yellow is 4 to 6 contacts, and your red is 7 to 9 contacts. And they, as you can see, there's no real difference between if your age, your sex, your ethnicity, or where you live, which was really reassuring. However, there was a difference in how many times you went to see a healthcare professional based on your diagnosis. So by diagnosis with lymphoma, those with CNS tumours, so brain or spinal tumours, those with bone tumours and sarcomas had the most visits prior to diagnosis. The last 3 groups here had small numbers with each group, so needed to be interpreted with a little bit of caution. We also looked at how they came to us. So 67% or 2/3 were diagnosed as an emergency presentation. And that means they came to A&E either via their emergency GP referral, from a transfer from another hospital, or a self-referral. And of these 2/3, half of them had come on their own. So they just turned up on their own without having seen anyone just prior to coming to A&E. The subgroups with more emergency presentations were leukemias, CNS tumours, renal tumours, neuroblastomas, and germ cell tumours. When we looked at the symptoms, there were a total of 63 different symptoms that were reported. Now, approximately half presented with 3 or fewer symptoms, whilst 15% presented with 7 or more symptoms. Now, the most frequent symptoms were tiredness, fatigue, fever, loss of appetite, looking pale, and vomiting. Now, this does highlight how difficult it can be to diagnose cancer. And it's really hard because these non-specific symptoms overall are unlike adult cancers. So, for example, for breast cancer, you will feel a breast lump, whereas the tiredness, fever, looking pale and vomiting can be due to other more common illnesses like viral illnesses. And this is where these children can often be have a bit more of a delay to their diagnosis. So this bottom picture here tells you what symptoms they presented with by age group. And this was really important to us because it means that later on, when I tell you about the time to diagnosis, especially for young people, because they present with different types of tumours as well. So what we found actually with this is that looking at symptoms by tumour type was a lot more helpful for us. So being able to say that children with leukemia will present with these types of symptoms, children with brain tumours will present with these types of symptoms is easier for us to use when we're educating healthcare professionals. Probably less so when speaking to the public and to parents. But this was an important lesson for us. Now we look at the interval data. By that, we mean the time to diagnosis. And like I said, we looked at 3 different times. So the patient interval, which is time from symptom to the patient or the parent recognises that symptom to going to see a healthcare professional, and then the diagnostic interval is from seeing a healthcare professional to diagnosis. And this just tells you how many children were included in that analysis. So looking at the intervals, the box plot, so these are these little, don't know if you can see my cursor, but these are these little boxes. We call them a box plot. And this number in the middle tells us the kind of average, we call it the median time to diagnosis. So overall, for all children in the study, the median time to diagnosis from first symptom was 4.5, just over 4.5 weeks. And that means half of these children were diagnosed within 4.5 weeks, and the other half took longer. Patient interval tells us that on average, 50% of children and young people saw their first healthcare professional within a week, and the others took longer. And then you can see this diagnostic interval was just under 2 weeks on average. Now, when you look at this graph over here with the green and the blues, what you can see here is that the majority of children and young people present within 4 weeks. This is the green here. And about 10%, 3%, and 6% had a kind of a TDI, a PI, and a DI, which was over 6 months. Now, if we look at the age box plots here, you can see that with each of these intervals, your interval increases as your age increases. And that was what we call statistically significant. So we would expect that to be a true result. There was no difference by sex. There was no difference by ethnicity. And there was no difference by IMD, or index of deprivation. There was some significant difference by region. So your PI, which is here, was shorter in England and Wales, but longer in Scotland. However, when you looked at your DI, it was longer in England and Wales and shorter in Scotland. And we don't really know the reason for that, but that's something that we need to look into. As expected, there were significant differences by diagnostic subgroup. So the diagnoses with the shortest intervals were renal tumours, leukemias, and retinoblastomas. And those with the longest were bone tumours, carcinoma and melanomas, and Langerhans cell histiocytosis. Now, what we have to remember is the numbers were quite small in our whole total group of these two. So we need to just be a little bit mindful of that. We also looked at the first healthcare professionals they saw, and actually children were seeing over 15 different healthcare professionals. 57s, just over half, saw their GP, and 27% went to A&E first. Now, your time to diagnosis was shortest when you went to A&E or used NHS 111, and it was longer when you were seeing your GP or subspecialty doctors. Now, we often talk about a delay in diagnosis for children and young people, but actually there is no definition for it, okay? So we had to use some what we call proxies to see whether we could find any factors that would be associated with a longer delay, or delay in inverted commas. So we chose a total diagnostic interval in the top quartile, so those children that were taking longer than 11.5 weeks, and those that were taking longer than 6 months. And when we pulled that out, we could see that actually age was a significant factor for both. So you can see this red bar is going higher as you go up. And then the type of tumour that you had also made a difference as to whether you were more likely to have a longer time to diagnosis. And this is just a graph that shows the same. So the types of tumours that we're looking at are bone tumours. We're looking at lung cancer, histiocytosis. We're looking at brain and spinal tumours as well, in particular. So the take home from this research was that there were some things that we could celebrate, which were that there was no difference in time to diagnosis by sex or ethnicity or index of multiple deprivation, which we were quite concerned that there would be a difference. But young people and bone tumours need really urgent focus so that we can close this gap for them. So what we're going to start doing as well is collecting follow-up data for these children so that we can see whether they relapsed, whether they had refractory disease, and looking at their survival as well, because there's not a lot of data out there to see whether reducing those intervals will make a difference. And this data has been used to inform the National Cancer Plan and, of course, Child Cancer Smart, which is what we're talking about today. So like I said, on the back of this, what we really wanted to do was raise awareness of the signs and symptoms of childhood cancer. But also through this work, we realised that it wasn't as easy as raising awareness of the signs and symptoms. And like I said, within the looking at the data, it was quite hard to use all the symptoms overall, and it was looking like it was better for us to split them up into by tumour type or by cancer type, to be able to raise awareness that way. So instead, we've launched in August looking at a overall key message about what actually makes cancer in children and teenagers different to normal childhood illnesses so that we can spot this. And this was some work we did with focus groups with parents who had a child with cancer and parents who didn't have children with cancer. And we spoke to them about their experiences and their perceptions of what childhood cancer is. And the parents of children who had cancer told us that actually they knew deep down that the symptoms that their child and young person had was different to what they normally had when they had an illness. And what they said made us think about how we can help both healthcare professionals and parents and carers and young people as well to see their doctor or to come back to us. So cancer symptoms often present as clusters. So like I said, when we looked at those charts, clusters depending on their cancer type. The symptoms of childhood cancer also persist. So they go on for longer than we would expect. They don't really improve or go away like other childhood illnesses. And also what we find is that it can be progressive. So they can start with one thing like a headache, but as the tumour grows, there'll be other symptoms that come along and accumulate. And that's something that's really important to look out for. Based on those focus groups, we wrote our parent message, essentially written by parents for parents. So trusting your gut was something that is also in our clinical guideline, that parental gut feeling or instinct should be taken into account. So if things still aren't right after 2 weeks, go back and see your doctor. So it may be that you've already been to see your doctor and they felt, based on the symptoms that you had, that it's most likely to be something like a viral illness. But if things aren't getting better and they still aren't right, or your gut just says it's not right, then go and see your doctor again. And that is our key message for parents. We also have this very pretty looking poster, which actually shows by body part what different types of symptoms children present with. And we thought that this would be more helpful for parents to be able to look at this and identify what kind of symptoms your child may have. Now, it's really important for me to stress that even if your child has 2 or 3 of these symptoms, in the majority of cases, this is not going to be cancer. But we hope that this empowers you to be able to go to your doctor and say, well, actually, my child's got this, this, and this. And moving on from this, we have a message for healthcare professionals. So again, there are some cancer types like leukemia or retinoblastoma, like we saw in the evidence, that are picked up a lot quicker. And it may be that because they are visible symptoms that you can see on your child, and those children will be investigated and picked up quite quickly. Now, some of the other cancer types are more difficult to pick up. And so what we want is to catch those children and raise awareness. So if your child has 3 persistent symptoms, has come back 3 times, or has 3 weeks of unexplained symptoms, we're asking healthcare professionals to think cancer. And this is really timely actually today, because obviously Jess's rule has been launched this morning and has been on the news today. And I'm sure all of you or many of you have seen it. And for them, it's a message to primary care to say, if you've had 3 strikes, then rethink. And this was something that we have already thought about. And this is for all healthcare professionals that are involved with children. And our poster for healthcare professionals is by cancer type, mainly because this is how it makes sense for us as healthcare professionals to be able to look at. And so when you, as a parent, go to your healthcare professional with your symptoms by body part, it's about a healthcare professional looking at it from a cancer type point of view and seeing whether it fits and following the guidance to investigate if needed. So I've just got a little video here. Our ambassador, we're really, really lucky to have Dr. Amir Khan. He's a GP and he is the ambassador for our campaign, and he has a message that essentially just summarises everything that I've said, but is something for you all to have a little listen to, if I can get it to her.
As a GP, one of the most important things I can tell parents is that you know your child best. Most childhood illnesses clear up within a couple of weeks, but if symptoms don't go away after 2 weeks or something just doesn't feel right, always trust your instinct and speak to a doctor. Remember, you're never wasting our time when it comes to your child's health. In fact, in diagnoses of children's cancer, there's strong evidence behind parents having a gut instinct that something was wrong. Published research shows that parental concern is really important, and that's why it's included in CCLG's, the Children and Young People's Cancer Association's clinical guidelines for GPs and healthcare professionals when assessing possible cancer symptoms. If you're unsure whether to make that call, here are some things that might help to keep in mind. Number 1, cancer symptoms tend to present as clusters, multiple symptoms showing up together. Number 2, childhood cancer symptoms often persist. They don't improve or go away like other common illnesses do. And number 3, symptoms can be progressive. A child may start with a simple headache, but over time it can get worse, symptoms can develop. If that sounds familiar, trust your instincts and go and see a doctor. If you're worried about your child's symptoms, you can use CCLG's list of symptoms on their website to help discuss things further with your GP. Whether you're a parent, teenager, carer, or healthcare professional, learn to spot the signs at www.cclg.org.uk/child cancer smart.
Fantastic.
As a GP,
oh gosh, sorry. We are back on. Okay. So what's next here? Based on all the evidence that I have shown you, we know that we need to focus on young people and on bone tumours. So that is what we're going to be doing next. And so please watch this space. And I suppose the message from the talk was, how can you be child cancer smart? A lot of this is about, for us, raising as much awareness as we can. So we'd really love you to share the campaign, share the messaging with your loved ones, with schools and nursery settings, just to make sure that we can try and have everyone spotting the signs and symptoms early, and being able to empower you all to reach out to a healthcare professional if you need them. Thanks, Ellie. Sorry, that was super, super quick.
No, it was brilliant. Thank you. Yeah, and I I forget how good Mia's video is as well, and then I see it and I'm like, we already have 4 questions, if that's okay. If you wouldn't mind
Absolutely.
stopping sharing your screen, and then we can all look at you while you answer them.
Fabulous.
Thank you. Okay, so the first question is from Ken. So he asked, for HeadSmart, you sent out tens of thousands of symptom cards and leaflets. Do you plan to do the same for each Child Cancer Smart group, like well, not brain tumours, because that's done. You know what I mean, like leukemias and that stuff.
Hi, Ken. Thank you for your question. So yes, so we do have a plan to bring out some symptom cards and distribute them. What we didn't want to do was send out, like I said, really, all the symptoms as a big long list. So what we're planning to do is to do that when we do launch the individual campaigns or sub campaigns, such as for bone. So we will have specific advice and cards that will be sent out for those.
Brilliant, thank you. Okay, so another question. So you didn't find many differences socio-economically, but did you find any delays for patients where English wasn't their first language?
That's a really, really good question. Unfortunately, we didn't collect data on that. So it is a shame because I really, my gut feeling would be that there probably would be, but that's how I felt about ethnicity and IMD, and we were surprised to find that we weren't. So that's something that would, when we're collecting further data, because we're hoping to collect some more data, we will hopefully maybe be able to go back and ask for that data.
That sounds brilliant. So another question, for dentists, are there any oral signs and symptoms that they should look out for?
For dentists, okay. So that's really, really good question as well. In terms of healthcare professionals seen, dentists were one of the ones that were seen, but only by a very few. And I imagine those children, young people would have been with soft tissue sarcomas. So there would have been masses that they would have seen in the mouth or neck or jaw area. It could also be that they were some bone sarcomas. So again, any kind of bony masses in the jawline, if they're when they're seeing patients. That what we hope to do at some point is to develop particular resources for different healthcare professionals by doing further analysis of the data. So hopefully there'll be more specific information.
Brilliant. And my last question for now, unless anyone wants to give me more, are healthcare professionals face a difficult choice as most symptoms don't have a cancer cause, but should doctors more routinely extend testing even if the possibility of cancer is low, for instance, doing MRIs for bone cancer or screening for ctDNA?
So it is really hard, isn't it? I know that none of us want to miss a diagnosis, and it is really hard to make that call. Now, what was really good about HeadSmart, and is what we're going to be doing for all the other cancer types, is having some really good decision support tools. So with HeadSmart, we had a reassure, review, and refer. And so it was really clear criteria and clinical guidance as to who they needed to scan and who they didn't. And I think that will hopefully answer some of your question in terms of if they've got robust, really good evidence-based clinical guidance to know who to scan and who not to, and more importantly, who to bring back and review to make sure that they then don't need scanning a week down the line or 2 weeks down the line. I would hope that we would be able to do investigations in a more timely manner rather than doing more investigations, if that makes sense.
Definitely. Yeah, I suppose you don't really want to be putting small children through MRIs when they're not necessary. I don't like MRIs and I'm an adult. So. So the last question I have is, are there any plans to translate your work to other languages?
Yes, there is. So what we're hoping is that, and we've just been talking about it in terms of with the website being able to figure out a way where we can easily have people translate into different languages. And now with all the AI and chat GPT and things, it is a lot easier for us to be able to do that more readily. And so that is something that is on our priority list.
Might as well make use of exciting technology. Oh, I've just had another question. So it is important, it's less of a question, more of a statement, but I will read it. It is important to know that in rare cases, the times are very short for increasing and worsening symptoms. Repeat visits to the GP in the matter of hours and days as opposed to weeks.
Yeah, absolutely.
There's I think when you were designing the messaging, there was a question of like, obviously, if it's been 2 weeks, that's concerned. But if you feel like it's serious, go now.
Yes. So what we were trying to capture is that, and on the website it does say very clearly, if you are worried at all that this is serious, call 999 or go to the emergency department. And so our messaging was more for those when we listened to the stories of parents who had a lengthier diagnosis. Often it was that the symptoms were lingering and they had been a few times, and but they trusted that it was something like a viral illness, so they didn't want to go back. They felt bad going back. And so part of this messaging for us was to empower parents to say it's okay to go back. Just like Amir said, you're not wasting people's time. And hopefully it becomes a bit more of a partnership because you've got information in your hand. And you can take it to the healthcare professional, who can also look at healthcare professional stuff on the website, and it's more of a kind of collaborative effort to get to a diagnosis or to reassure you even that it isn't the case.
So I think that is all of our questions, unless there's anything you'd like to add. I do have a read again, but if you have any take-home messages for anyone, Shaarna?
I know I thought that I thought that my talk would take a little bit longer, but it's a little bit of a whistle-stop tour, really. It's been really timely because we're in Childhood Cancer Awareness Month and we have just launched the campaign. It's at the very beginning, and the key messages are something that we've really wanted to kind of hone down on before starting the specific campaigns. I suppose my take home for everyone is please don't sit at home and worry about something. We are obviously, as healthcare professionals, it's always busy, it's always difficult, but we are here to look after your child and to see your child. So please trust your gut instincts, and please tell us what you're worried about as well. Sometimes we don't always ask, what is it that you're worried about? But if you are concerned that it's something like cancer, please tell us, because sometimes it would just, number one, it will, trigger something potentially in the healthcare professional. If they weren't thinking about it, it might make them think about it. And if they were thinking about it and they didn't realize you were thinking about it, it may be that you have a really reassuring conversation. And that did happen to me the other day when I saw a child with headaches in A&E, and I had safety netted them. I said, right, it's been 2 weeks, it's likely to be viral, I'd like you to come back next week if it's still going on. And I'd gone through all of it thinking, in my head, I was thinking HeadSmart. But again, as healthcare professionals, we don't always want to put that into some, want to say that and worry everybody when actually the likelihood it's not. And at the end, before they left, Mum said, well, are you sure? Are you certain that this is not a brain tumour? And then it was really easy for me to have the conversation and say, well, actually, I've followed this guidance. It's been 2 weeks. It's still most likely to be viral. I've asked you to come back next week. And actually, we would only scan you if it was after 4 weeks. So even when we see you next week, we wouldn't necessarily be scanning you. And then I showed them the kind of HeadSmart guidance and gave it to her to say, you know, have a look at it at home. If anything changes, come back. And actually, that's then a really reassuring conversation for both parties. And so please don't ever be worried about asking that question to your healthcare professional so that they can talk it through with you.
Yeah, great take-home message. I would also say, don't worry about the webinar being shorter. I think it speaks to how much effort you've put into refining Child Cancer Smart, that from all that data into just like the perfect messages.
Oh, thanks, Ellie.